Yes, I'm presenting this on behalf of Dr. Boissier, who couldn't be here today. So we have talked about clustering, and we go back to the fact that ASD is a very heterogeneous population, and the patients have very different characteristics. There have been a lot of classifications attempts, starting from the classification based only on coronal alignment, later on Lenke classification, sagittal parameters as well, and then the Schwab classification with the inclusion of disability parameters, and Dr. Ames was the first one to introduce the use of machine learning for patient clustering. Now, why do we need patient clustering? As we start from a very heterogeneous population, clustering helps us create homogeneous groups of patients, and this in turn allows us to perform comparison analysis or prediction analysis that would otherwise be not possible starting from a heterogeneous population. And obviously, though, clustering is based on the characteristic of a patient, so it's logic that the cluster are going to depend from the variable inputs that we start our model from. So the question was, if we use different variables to start with, how are the results going to change? So what we did was to take the same patient group and cluster it with two clustering methods, one based on 12 variables and more heavy on the radiographic parameters, and the second one 16 variables, but more heavy on the clinical data. We had data from 784 patients, and this is what we saw. So in both cases, we obtained 3 clusters. That was the same in both analyses. And then if we look at this in more detail, this is the clustering method with 16 variables, more reliant on clinical parameters. We see one cluster, young patients with coronal deformity, older patient with mild disability, mild sagittal deformity, older patients with a more severe deformity and a more severe malalignment. Now, does this sound familiar for what we have just seen in the previous study, right? But if we look on the right, this is what's called a principal component analysis, and this is the analysis that tells us what are the variables that are the most important in determining which cluster is a patient going to belong to. The more the variable shifts to the red, the more it is close to the circle, the more this variable is important. And in this case, we see, for example, SRS-22 inverse ODI were among the most important parameters. And now, if we have a look at the other method with 12 variables and more reliant on radiographic data, we see that, again, we have one patient cluster with patient with no disability and coronal malalignment. Second cluster, moderate sagittal imbalance, moderate disability, more severe disability with coronal and sagittal malalignment, which were all more severe if we compare the data with those from the previous clustering method. The big difference that we see now is, again, if we look at the PCA, the principal component analysis. In this case, we see that radiographic parameters, pelvic tilt, global tilt, LLI, were the ones that were the most important in determining which group would the patients be clustered into. So what is the take-home? The take-home is that clustering method is important. The kind of variables that we choose is obviously important. But irrespectively of what variables we choose and how many variables we choose, we're going to obtain a cluster of patients that are actually quite similar to one another. The variable choice is still important because the variable choice will determine the granularity and the detail of the information that we're going to obtain from a specific cluster. So obviously, if we want to think about a study on clinical parameters, then it's going to be useful to use more PROMS, health-related quality of life data. For a study on, for example, mechanical complication, the use of radiographic parameters might be more meaningful. So similar clusters, but it gives a bit more detail and granularity depending on the study that we want to perform. Thank you very much.
Thank you, Alice.